Welcome to this presentation on understanding common arrhythmias and conditions. By the end of this session, you will be able to understand common signs and symptoms of arrhythmias and other ECG findings in the clinical setting, as well as describe best practices and next steps to be taken by a registered cardiology technologist. Symptoms of an MI can sometimes be subtle, especially in elderly patients or those with diabetes. For example, they may present with only generalized weakness or dyspnea. The ECG and blood work are invaluable diagnostic tools here, with findings like ST elevation, indicating acute coronary occlusion and elevated troponin and CKMB. Don't forget to compare the ECG with previous ones to identify changes over time. Conducting a 15 or 18 lead can also reveal posterior or right ventricular involvement, which is crucial for guiding treatment decisions. SVTs are often triggered by stress, stimulants, or structural heart abnormalities. It can also be a complication associated with pre-excitation, such as Wolff-Parkinson-White syndrome, or WPW for short. Because WPW can be detected on an ECG, this is why previous ECGs may be invaluable. Vasovagal maneuvers like bearing down can terminate SVTs in some cases. If these fail, medications like adenosine can be administered in an acute setting. It's also worth noting that long-term management may include ablation therapy for recurrent SVT. Atrial fibrillation and flutter are common arrhythmias in the clinical setting. In fact, atrial fibrillation is the most common rhythm disturbance encountered in patients over the age of 65. Cardioversion is typically attempted within the first 48 hours of onset to minimize risks associated with thrombosis. For patients with atrial fibrillation lasting longer, anticoagulation therapy is critical before attempting cardioversion. Another factor to consider is rate. Rapid atrial fibrillation and flutter is a type of SVT, and hence can have similar signs and symptoms to other SVTs. Ventricular tachycardia, or VT, is a life-threatening arrhythmia. Quick recognition is essential since it may not self-terminate and even degrade to ventricular fibrillation. VT can sometimes be pulseless, in which case it must be treated as a cardiac arrest. For stable VT, pharmacological options like amiodarone or procainamide are often used, but always be ready to escalate to cardioversion or defibrillation when necessary. Ventricular fibrillation is characterized by chaotic, disorganized electrical activity, and defibrillation is the only definitive treatment. Patients with this rhythm can be considered clinically deceased. High-quality CPR between defibrillation attempts is crucial to maintain perfusion. Medications like epinephrine can increase the chances of survival, especially when used alongside early defibrillation. First-degree AV block and Mobitz 1 are often benign and may not require intervention, particularly if the patient is asymptomatic. However, Mobitz 2 and third-degree AV blocks are considered serious and can lead to hemodynamic instability. Temporary pacing may be required while preparing for a permanent pacemaker implantation. When analyzing ECGs, pay attention to the PR interval and regularity to differentiate between AV blocks. Performing a rhythm strip may prove helpful in cases where an AV block is transient or subtle. Since cardiologists typically do not have the patient in front of them when interpreting and confirming ECGs, cardiology technologists play a vital role in capturing ECG findings and recording any pertinent information in the comment section of an ECG that physicians may use to aid them in their diagnoses. Also, paroxysmal arrhythmias may not be evident on standard tracings but could be captured during episodes of palpitations or bouts of dizziness. Ensuring rhythm strips are recorded during key moments is very helpful. The timing of ECG printing is another critical aspect. Capturing transitions like onset and offset of arrhythmias provides valuable diagnostic information about the mechanism of the arrhythmia and how to best guide treatment. Let's look at the following scenario. A 55-year-old patient arrives at the clinic complaining of fatigue, dizziness, and the sensation of their heart racing. During the ECG, the technologist identifies a regular rhythm with a narrow QRS complex and a heart rate of 180 beats per minute. The patient mentions feeling lightheaded and experiencing chest discomfort radiating to the throat. Based on the scenario, what should the technologist prioritize? Is it A, notify a physician immediately and prepare for potential vagal maneuvers or medication administration? Is it B, reassure the patient and make a note on the ECG for a follow-up? Is it C, compare the current ECG with a previous one to check for Q waves? Or is it D, compare the current ECG with the previous one to check for a history of third-degree AV block? Because the scenario describes an SVT, the correct answer is A. B is incorrect because cardiology technologists do not order follow-ups as this is the physician's call. C is incorrect because this selection implies that the patient is having an MI. While the patient has chest discomfort, this can be associated with elevated heart rates as there is an increased myocardial demand and less time for ventricular filling. D is incorrect because a history of third-degree AV block is not directly correlated with SVTs.